Moving to the next talk, operable versus inoperable biliary neoplasms, presented by Dr. Madhu SD, Professor and Head, Chief Interventional Radiologist, Department of Radiology, Kidwai Memorial Institute of Oncology, Bangalore. We welcome you on stage, sir.
At the outset, I would like to thank the organizing committee for this opportunity. So next 20 minutes or so, we're going to discuss on the biliary neoplasms, how to identify them, how to diagnose them, and assessing the operability versus inoperability. So the biliary malignancies are the second most hepatobiliary cancers. First one is the HC. Okay, thank you. So, the biliary malignancies are the second most malignancy after the HCC, and these tumors are quite slow growing in nature, and also they present with very non-specific symptoms. Many of the times, it becomes very, like, by the time we diagnose, it's already too late. So accurate characterization and staging of these indolent cancers determine the overall outcome of the treatment. So pathology-wise, this can be divided into cholangiocarcinomas, both intra and extrahepatic, the CA-GB and periampullary CA. These group fall into the biliary neoplasms. Most of them are adenocarcinomas, but we do see a lot of variants in this. So clinical presentation usually depends on the site where they come from. The mass forming cholangioCAs, usually they present late because they won't present clinically at all. So stricture forming ones, like in the perihilar location or in the distal CBD or the periampullary region, they present with obstructive jaundice. Usually they present early, but the periampullary, even if they present early, they already shown a lot of local infiltrations, which makes it inoperable. So otherwise, apart from these, if they do surgery for cholecystectomy for some other reason, on histopathology they may find CAGB in that, or incidentally on CT-MRI for some other reason they may detect the lesion. That's how they're going to present. Imaging wise, USG is the initial modality of choice. MRCP with MRI is the modality which answers many questions in these kind of malignancies. ERCP with endoscopic ultrasound is the modality which is regularly used for the distal CBD as well as periampullary CAs. So what is the role of imaging in these conditions? It's detection of the lesion, characterizing them, and also assessing the operability in these lesions. So coming to the cholangiocarcinoma, this is the most common biliary malignancy. Seventh decade male are usually affected more than the females. Had a poor prognosis, and 5-year survival rate is only 5%. It has a distinct geographic presentations, like the Southeast Asians, and in India it is the Northeast population. They usually affected with this disease. The reason being, liver flukes and chronic typhoid carriers are more common in this age group, in this area. Other risk factors include primary sclerosing cholangitis, choledochal cyst, familial polyposis. These are the other risk factors which are associated with cholangioCA. So again, cholangioCA has been classified into intrahepatic cholangioCA, perihilar cholangioCA, distal cholangioCA. This intrahepatic cholangioCA is divided into mass forming, periductal infiltrating types, and as well as intraductal polypoidal types. We'll just go to the classification. So in the cholangioCA, the intrahepatic variety itself has 3 forms. Most commonly what we see is the mass forming peripheral ones. So the next is the perihilar ones. These are the ones with presents with the obstructive jaundice, and the distal ones. So up to the level of cystic duct insertion, it is the cholangioCA, and below that it is called as distal CBD malignancies or the periampullary malignancies. Coming to the role of imaging in cholangioCA, it is to detect and characterize. Why to characterize? To differentiate from other tumors like HCC, metastasis, and to establish the presence of any satellite lesions. Small satellite lesions are known with these kind of malignancies. This is very important from the operative management. So MRI is the modality of choice in these conditions. And next is assessing the relationship of the tumor with respect to the hepatic artery, hepatic vein, biliary ducts, and portal veins. This is important from the operability point of view and assessing the extrahepatic nodes, especially the one which are there in the retroperitoneum. So distant metastasis, assessment of the distant metastasis including the pulmonary and the peritoneal, and modality used for the intrahepatic cholangia mass forming wounds is the CECT, triphasic CT. We regularly do it. So the intrahepatic cholangiocarcinoma usually arises distal to the secondary branching of the biliary ducts, and they are usually adenocarcinomas, highly infiltrating. The peripheral margin is the infiltrating margin, which is quite ill-defined, whereas the central area is a necrotic mucin-containing area that usually shows late enhancement, and it contains a lot of fibrous under the desmoplastic reaction. So typically how it looks like, the mass forming one. In ultrasound, it looks like a hypoechoic lesion, most of the time ill-defined with the infiltrating margin. On CT scan, you can appreciate in this, a plain CT scan an ill-defined lesion with a capsular retraction, that is because of the desmoplastic reaction. In the arterial phase, hardly any enhancement. When in the portal venous phase, you can appreciate subtle enhancement, more of necrotic area in the central, subtle enhancement in the periphery. That enhancement progresses in the delayed phases. As we go towards the delayed phase, the enhancement increases. This capsular retraction delayed enhancement is basically because of the desmoplastic fibrotic reaction which happens within the tumor. The contrast goes in late, comes out late. That's the reason why there is a delayed enhancement. Capsular retraction and distal biliary radical dilatation is because of the fibrosis. This is a classical example of cholangiocarcinoma, how it looks, the peripheral mass forming one. The same thing with MRI. The diffusion weighted image usually helps, where the lesion it looks at us. It's very easy to pick up, and typically in MRI also it shows peripheral delayed enhancement. So other variety is polypoidal type. In the polypoidal type, we can appreciate a small polypoidal lesion within the biliary radicals, and also it try to infiltrate into the wall. This is a typical form of a polypoidal one, and it is usually seen in the primary or the secondary ducts. What are the signs of inoperability in case of a cholangiocarcinoma, intrahepatic cholangiocarcinoma? One is multicentric. If the lesion is multicentric, you cannot operate. So this is better recognized with the MRI. That's why MRI is the modality of choice whenever you're suspecting cholangiocarcinoma. So, satellite lesions in other lobes. This is again MRI which picks up these lesions. Metastatic nodes in the retroperitoneum, peritoneal or distal metastasis, involvement of the contralateral hepatic artery, portal vein and biliary radicals. This is very important to mention in our report. Whenever this is present, it becomes inoperable. Also, future liver remnant. This we are going to calculate regularly on a CT scan, and we will provide this data to the surgeon before operation. If the FLR is less than 30% in a normal liver, and if less than 40% in case of a liver with fatty changes, then the surgery cannot be done. These things should be mentioned in our reporting. Coming to the perihilar one, these are very important one. Regularly we see these kind of tumors with obstructive jaundice. So these tumors arises anywhere between the second order biliary radicals up to the CBD till cystic duct origin. So these are the perihilar tumors, and there are a few subtypes in this: nodular, sclerosing variety, and papillary subtype. Sclerosing variety is the one which we commonly encounter. This is nothing but a periductal infiltrating kind, and this presents most of the time with a dilated IHBRD with a obstructive jaundice. So it spreads by perineural invasion and lymphatic metastasis. So these tumors, most of the times, they at the time of presentation itself having a metastatic nodes. So we know Bismuth classification. So this is the just schematic diaphragm of the same. I don't want to go into the detail. Coming to the imaging, what are all the things we need to assess? So where exactly is the tumor? What is the location of the tumor? Size of the tumor? What are all the ducts it's infiltrating? What are like right, left duct, in that primary duct, secondary ducts? All these information has to be given. Then what are all the vessels it is close to? Is it close to hepatic artery, portal vein? How are the hepatic veins? These are the information we need to give. Any satellite lesions which are present, any metastasis will be present, and nodes. All this information we need to give to the surgeon. This is a classical example of type 4 the perihilar cholangioCA. Here you can appreciate the second order radicals on either side are infiltrated by the tumor. So typically on a T2 weighted image, it looks like a hypointense lesion with abrupt cutoff of the biliary radicals. The MRCP clearly shows where exactly is the tumor. Even T2 weighted image, it's very well appreciated. Diffusion weighted image, you can see linear areas of restricted diffusion. This is a tumor growing along the ducts. That's why it is looking like a linear hyperintense restricted areas. So on a contrast, the legend shows a delayed enhancement. You can appreciate the enhancement along the radicals. So with respect to the operability, we need to mention is the primary or the secondary ducts are involved, which side, right or left, and the relation of the tumor with respect to the hepatic artery and the portal vein. This is another example where we have a lesion in the left primary biliary radical. Here you can see the secondary radicals are dilated and they're separate. They're not communicating. So this tumor is sitting in the left biliary radical, and you can see in the MRCP the confluence is good. Even the left primary radical is good. At this level, there is a tumor. This case, it's very easy. Even if the lesion is infiltrating the hepatic artery, left hepatic artery or the portal vein, doesn't matter. They can aramse go for left hepatectomy, and most of the time they are going to remove the segment 1 also. This is because the segment 1 is like the duct is has an anatomical variation, and it can insert directly into the left or into the main duct. In such a scenario, the removal of caudate lobe helps in achieving R0 most of the time. So that for that reason, they usually go for these cases. They usually go with the caudate lobe dissection as well. So this is the type 1 bismuth lesion, where you have a nodular lesion sitting at the CHD, not completely involving the confluence. So you can see the communicating right and left IHBRD. So these are the cases which go for depending on the involvement, right or left involvement. They'll go for either they'll go for hepatectomy, or they'll go for resection with a hepatogenostomy. This case, we have a lesion which is sitting in the left main biliary radical with a dilated ductal system with atrophy of the left lobe. In such a scenario, we need to mention which lobe is getting atrophied. Suppose if the lesion is here in the left biliary radical and left lobe getting atrophied, the relationship of this lesion with the right biliary radicals, the right hepatic artery and the right portal vein is very, very important, and that has to be mentioned. Suppose you have a lesion here on the left side, and this lesion is infiltrating the right hepatic artery or right portal vein, then it becomes inoperable. So you cannot compromise with the right hepatic artery when we are removing the left lobe. So these things has to be clearly mentioned in our report. So from the treatment aspect of view, we need to give a few important points to the surgeon about the tumor size, about specific location of the tumor with respect to the hepatic artery and the portal vein and its encasement if it is there. Then volume of the FLR, what I told before, the presence of liver metastasis, and all this information. So tumor, with respect to the tumor resectability, few of the important points we should keep in mind is the biliary tract anomaly. There is a lot of anomalous variation normally seen in many patients. We should specifically mention about if there is any anomaly, and with respect to the tumor, the relation of the anomalous ducts we should mention. The same way, like even the vascular anatomy, lot of variations are seen with respect to the hepatic artery origin. The anomalous right hepatic artery or the completely displaced right hepatic artery arising from the either SMA or directly from the aorta. All this information we need to give and also with respect to the relation of the these vessels with the tumor we need to mention. Coming to the oncological consideration with respect to the tumor resectability, complete resection of a localized perihilar cholangioCA is the only curative treatment available, and neither the chemotherapy nor the radiotherapy will treat these tumors. So keeping this in mind, we should give a complete information to the surgeon whether it is operable or not. The whole idea is to get a R0 resection. R0 means the tumor, the resected margin should be free of tumor. So usually the normally advocated method is either left or right hemilobectomy. The disadvantage with this kind of surgeries are they may left behind some of the tumor. The R0 may not be achieved. However, the FLR will be good. In case of right hemi resections, what they are going to do is they are going to resect right complete right lobe plus a segment 1. They are going to remove right like segment 1, 5, 6, 7, 8, right lobe plus segment 1. But here the problem is they cannot achieve R0 many times, but FLR will be good. Nowadays they have moved to right trisectomy, sectionectomy. In this they are going to remove the right lobe segment 1. Also they are going to take out segment 4. In this way they are going to achieve R0, but FLR will be small in this kind of cases. Likewise on the left side also they can do hemiapopectomy. That means to say they are going to remove segment 2, 3, 4 as well as 1. But again the FLR will be good, but R0 may not be achieved. When they do left hemitrisectomy, they are going to include segment 5 and 8 also. In this we are going to achieve R0, but FLR may not be sufficient. These are the things which surgeon will keep in mind while doing the surgeries. For that we should give what all the information necessary for the surgeon. So liver volumetry is the another thing what every radiologist should mention with respect to the liver tumors. So this liver volumetry either they can be done manually, automatically or semi-automatic way. So basically we need to give an idea, we need to discuss with the surgeon where his operative margins are, and we need to subtract that with the future liver remnant. So usually 30% is considered as a good FLR in case of a normal liver, and 40% if there is a fatty liver or a steatosis in the liver. So usually in such a cases we are going to do a biopsy of a remnant liver and assess the amount of steatosis or a fibrosis. Then we are going to assess the FLR. Coming to the criteria of inoperability in case of the perihilar ones, it is type 4 perihilar cholangioceae which are considered as inoperable most of the times. And as I told you before, the atrophy of one lobe with infiltration of the hepatic artery or the portal vein on the opposite, that is the other important one. Then vascular encasement or invasion of any of these vessels we should mention. Then metastasis to non-regional lymph nodes, to the peritoneum and to the distant organs. These are all inoperability from the surgical point of view. From the patient point of view, if the patient's factors are poor, like advanced age with poor performance status, inadequate FLR, these are the other indications where the tumor is inoperable. Coming to the distal cholangioceae, distal cholangioceae is nothing but the one which is arising behind the cystic duct. So they are usually the well differentiated adenocarcinomas, presents with a painless jaundice and cholangitis. They usually present early, carry better prognosis compared to other group of cholangioceae. Even the nodal metastases are quite less common in this group. On imaging, the key imaging features what we see is the thickening and stricture of the distal bile duct with a proximal dilatation. So endoscopic ultrasound is the important modality in assessing the tumor resectability. Local assessment is better with the endoscopic ultrasound. So in this kind of cases, Whipple surgery is the mainstay of treatment. So the overall survival is pretty good compared to others, and negative tumor margin is the important indicator for the overall prognosis, overall survival. Suppose if surgery is not possible, next step is the palliative either hepatogynostomy or biliary stenting. So what are all the conditions where it is inoperable? The distal masses which are inoperable when they are encasing the SMA or the main portal vein or the SMV, encasing IVC aorta, in these cases it becomes inoperable. So CAGB, when this becomes inoperable, when the tumor infiltrates, when the tumor infiltrates into the adjacent omentum, when there are omental deposits, when there are deposits in the peritoneum, metastatic lesions, and if it is infiltrating into the hilum, this becomes inoperable. Most of the time CAGB, when it presents at the time of presentation itself, it is inoperable. Just a few points on periampullary CA. There are two varieties in this. Pancreaticobiliary type is the most common variety, but it is having a worse prognosis. The interstitial type, it is very rare and it has a better prognosis. So imaging wise, it presents with a double duct sign, and differentiating it from primary ampullary CA is very difficult, but it's very important. The prognosis changes. So as I told you in on imaging, there will be either a small mass which is sitting in the distal CBD or presence with a double duct sign. So MRCP is the modality of choice in identifying these lesions. Endoscopic ultrasound is superior to other modalities in assessing the local infiltration. So the MRCP here in this image, MRCP is showing a double duct sign with a dilated CBD and the MPD. On CT scan, we can clearly appreciate an enhancing lesion which is sitting in the distal periampullary region. So what are the vessels we are going to assess in this region? The tumor may infiltrate into the adjacent the celiac trunk, SMA, SMB, portal vein. These are the vessels we need to mention in our reporting. So whenever we assess the tumor association with the artery, we are going to mention the arc of contact, whether it is 90 less than 90 degrees, 90 to 180, more than 180. Anything more than 180, it becomes inoperable. With respect to the vein, is it completely compressed or completely non-visible? That is what is important. This pinching and or this kind of deformation, they can the surgeons can handle it and they can do reconstruction. So these are a few examples showing the tumor infiltrating in the periampullary tumor infiltrating into the celiac axis as well as the common hepatic duct. Another important finding is presence of this soft tissue around the SMA in case of a periampullary tumor. The presence of soft tissue, even though there is no contiguous involvement, may indicate perineural infiltration around the plexus of the SMA. This indicates the presence of malignancy. So to conclude, the malignancies of biliary tract are quite uncommon compared to others, but they are associated with the poor prognosis, presents very late. CT, MRI, MRCP, and ultrasound, the endoscopic ultrasound are the most important modalities in assessing the resectability of the tumor. Surgical resection is the only mainstay of treatment, and rest of the things are palliative. So imaging plays a very important role in assessing the resectability. Thank you.
As they say, good surgeons know how to operate, better ones know when to operate, and the best ones know when not to operate. Thank you, sir. With this session, you emphasized on the crucial role of us as radiologists in guiding a surgeon in the management of biliary tumors. Next up, welcoming Dr. Raju Sharma, Professor of Radiology at AIIMS, New Delhi, on the stage for a talk on pancreatic cystic neoplasms. Can we make a sense of the guidelines?
I'd like to begin by thanking the organizers for giving me this opportunity. It's been a pleasure being here. Let's now switch gears and step into the pancreatic domain. What I hope to do over the next 20 minutes or so is talk to you about cystic pancreatic lesions. And we'll see where do we need to really intervene and where can they just be kept on surveillance. So the role of a radiologist when you're evaluating a cystic pancreatic lesion is first to discern whether it is really arising from the pancreas. Is it truly cystic or solid? Is it neoplastic or non-neoplastic? Because remember, it is the cystic lesions associated with pancreatitis which are the commonest and sometimes can mimic the cystic neoplasms as well. Amongst the tumors, we have the serocystic tumor, the mucinocystic neoplasm, solid papillary epithelial neoplasm, and the IPMNs. The management of some of these lesions is complex, especially IPMN, which is the commonest of these lesions, where only some of the lesions need to be operated, the others can be kept on surveillance. And then there is this huge debate of surveillance of these tiny white dots that are seen in the pancreas, and we really in this country cannot afford that luxury. The pooled sensitivity of MR is about 76%, specificity of about 80% in distinguishing benign from malignant lesions. And in spite of all the modalities available to us, there are areas where we can go wrong. This was a large study on about 600 patients where 50% of them had undergone even EUS, and the misdiagnosis was seen in 19% and a mismatch in 34%. The highest rate of misdiagnosis was seen in the cystic neuroendocrine tumors. Also, I'll talk to you about high-risk stigmata and worrisome features in IPMNs. It was seen that patients with the high-risk stigmata may turn out to have benign disease, whereas those without may turn out to have malignant disease. So there are areas where imaging can go wrong. So this just shows you the list of lesions that we can encounter in the pancreas, the cystic pancreatic lesions. On the non-neoplastic spectrum, you have pancreatitis-related collections and you have true epithelial cysts. On the neoplastic spectrum, we have two broad categories, the mucinous cysts and the non-mucinous cysts. It is the mucinous ones that we are more bothered about because they have malignant potential, and this includes the mucinous cyst adenoma, IPMN, serous cyst adenoma, and SPEN are the non-mucinous lesions. So let's begin by seeing the common things that you encounter in day-to-day practice. If you see a large lesion like this with fluid attenuation, without any solid areas, and there is a background history of pancreatitis, this is more likely to be a pseudopancreatic cyst. On MR, you can easily discern the purely cystic nature of the lesion and identify the lack of the solid components. Sometimes you may see solid components. That happens when you have walled-off necrosis in the setting of necrotizing pancreatitis. And then these lesions can mimic the cystic tumors as well, because remember, patients can present much later after the acute episode has subsided, and that history may not be forthcoming. And just based on the morphology, you may sometimes mistake it for a cystic neoplasm. It's not uncommon to see lesions like this, where the history of pancreatitis is not available, and you have this heterogeneous lesion with some solid-looking areas within the lesion in the tail of the pancreas, and then sometimes it may become difficult to distinguish between pancreatitis-related and neoplastic cystic lesions. Epithelial cysts typically occur in the background of entities like VHL, where you have cystic lesions in the kidney, a tumor, RCC in the kidney, and you have multiple pancreatic lesions in the background of VHL. This is what has been referred to as the grandmother lesion, typically occurs in the 6th to the 7th decade of life. There can be different phenotypes. You can have the polycystic variety and you can have the oligocystic variety. The oligocystic variety is more difficult to diagnose because it can mimic the mucinous tumors. Of these, there is no real malignant potential, and therefore lesions smaller than 4 centimeters in size can be just kept on surveillance. It is the larger lesions which produce symptoms that need to be operated upon. But remember, the serous cystic tumor does not have malignant potential. This is almost the textbook appearance of this lesion. It may appear solid on ultrasound because this contains numerous cysts, and there are so many interfaces for the ultrasound beam that it may actually look solid. It's on MR that you can actually identify the microcystic nature, the innumerable cysts that this lesion has on a T2 weighted image, and this typically shows you the central stellate hypointense scar. And with this constellation of findings, you're almost certain you're dealing with serous cyst adenoma, and if the patient does not have too many symptoms, this can be kept on observation. On CT, it may show you calcification in the central scar, but notice that it's difficult to discern the innumerable cysts that are seen, and that is perhaps done much better using MRI. Here's another example where CT shows you a relatively homogeneous kind of an appearance, but on MR you can identify the multiple small cysts within this lesion. You can also encounter multiple serous cyst adenomas in the background of syndromes like VHL. In fact, serous cyst adenoma patients have the mutation in the VHL gene, and that is very, very specific for serous cyst adenoma. Let's move on to the more ominous lesion, which is the mucinous cystic tumor, which accounts for about 8% of the pancreatic cystic lesions, typically occurs in the 4th to the 5th decade, more commonly seen in the tail. This is almost exclusively seen in the female patients, and this tumor is associated with ovarian type of stroma. The cyst fluid, when it's aspirated, shows you elevated levels of CEA and CA19-9. Cysts larger than 3 centimeters should be operated. Cysts smaller than that with no other risk factors may be kept on surveillance, but that is a decision of the multidisciplinary group. On ultrasound, you can actually count the number of cysts here. There are usually 6 to 7 not more than 10 cysts in a mucinous cystic tumor. On CT, you can identify multiple septations. Again, you can count the number of cysts. They are not numerous like the serocystic variety, and you may see nodular projections along the wall, which makes it a risk factor for malignancy. On MR, again, notice the cystic lesion, and there are solid areas from the non-dependent wall of the cyst, which suggests that this is likely to harbor a malignant potential and should be operated upon. Sometimes CT may show you a bland architecture. This just shows you a large cystic lesion in the region of the pancreas. You do an MR and you can see the internal architecture. There are multiple septations. So MR is much better than CT in identifying the internal architecture of these mucinous cystic neoplasms. You inject gadolinium and you can see enhancing components within this, the thick enhancing septations, and on surgery this was found to be an invasive carcinoma arising in a mucinous cystic neoplasm. IPMNs are the most common cystic lesions in the pancreas, and they are being recognized increasingly because of imaging being done in patients for so many other reasons. The hallmark of this lesion is that it communicates with the pancreatic duct. There are three different phenotypes. There is a main duct type, which has the highest malignant potential, but is not so common. It is the side branch type, which accounts for 40 to 60% of patients. This does not have too much malignant potential. And then there is a mixed form where both the main and the side ducts are involved. Hallmark again is communication with the pancreatic duct. MR is again superior to CT in showing that communication. This is considered a macroscopic precursor of invasive ductal carcinoma. The main duct type especially has a malignant potential, and therefore multiple guidelines are in place. The ones that we follow currently are the Kyoto modification of the guidelines given by the International Association of Pancreatology. There is also a concept of field effect, which I'll talk of in a little while. So again, this image I have taken from Pancreatology Journal. These are the three different morphological types. You have the branch duct type, where only the side branches are involved. This can be multifocal. Then you have the main duct type, where you have this kind of dilatation, marked dilatation of the main pancreatic duct. Again, this can be segmental, or the entire pancreatic duct can be involved. And then you have a mixed type, where both the main duct as well as the side branches are involved. This can be sometimes difficult to categorize it as a mixed type of lesion, because sometimes there is side branch dilatation, there is main ductal dilatation also, but you're not sure, is it just because mucin is being secreted and mucin is blocking the duct, or is it actually involved in the neoplastic process? There are three different histological forms of the lesion, which are associated with a different degree of dysplasia. There is a gastric kind of histology, which you can get in IPMN, an intestinal type, and a pancreatico-biliary type. There used to be a fourth type called the oncocytic type of histology, which has now been separated into a different tumor because it's associated with different genetic mutations. Let's look at some examples. This is gross dilatation of the main pancreatic duct. Remember, this degree of dilatation can almost never be seen in chronic pancreatitis. This is measuring almost 2 centimeters, and within the duct you have either these echogenic lesions can represent mucin, or they may represent nodules of the tumor. MRCP of the patient shows you this marked dilatation of the main pancreatic duct. You inject gadolinium, and if you can pick up enhancing nodules within that dilated duct, that is a sign of an ominous sign that the lesion may be harboring malignancy. Branch duct type involves the head region more often. Notice that only the head and the proximal part of the pancreatic duct is involved. This can be multiple in almost 40% of cases, and the malignant potential is thought to be much lower as compared to the main duct type. And this is a mixed type where the main duct is involved as well as the side branches in the uncinate process are involved in a mixed type of IPMN. These patients, when they show ominous signs or worrisome features, are frequently subjected to endoscopic ultrasound, and that's an EUS appearance where you can see this nodule, and they can even inject ultrasound contrast during EUS, and if you can show enhancement of this nodule, this would then become a high-risk feature and the patient would require surgery. It's not always easy to establish the communication. Sometimes it may be difficult, as is seen in this patient, that you have a cystic lesion in the head, but it's difficult to say whether it's communicating with the pancreatic duct. It's not the easiest of things to do that, and sometimes an overlapping duct may fallaciously give the appearance of a communicating duct. So these are the criteria that we are familiar with, the Fukuoka criteria. This is a busy slide. I won't have the time to go into details, but we have some high-risk stigmata which make it an indication for surgery, and there are some worrisome features which then necessitate that you subject the patient to an EUS and better study the morphology of the lesion. Recently, these have been modified. There is a 2024 Kyoto modification of these guidelines, and this is a paper that those of you who see these lesions on a daily basis may want to read, because they have modified some of the high-risk stigmata. The three important ones are, of course, obstructive jaundice clinically, enhancing mural nodule larger than 5 mm, and a main pancreatic ductal dilatation of more than 10 mm. These become indications for surgery. There is a long list of worrisome features. The ones that have been recently added are cyst growth. A cyst growth of more than 3 mm per year has been included now as a worrisome feature, and you need to evaluate this patient in greater detail, either by EUS or an EUS-guided FNAC. Branch duct IPMNs are the ones which are even more complicated, because they may be kept on surveillance unless they show some of these worrisome features that I have been talking about. There have been guidelines laid down for how you should keep them on surveillance. Cysts smaller than 2 centimeters, surveillance every 6 months, once at 6 months, then every 18 months. Cysts between 2 to 3, once at 6 months, then yearly for 2 years. And cysts larger than 3 centimeters should need to be evaluated using either MR or EUS every 6 months. There is also an increasing trend that you may stop surveillance in those branch duct IPMNs which are less than 2 centimeters and remain stable for 5 years. Earlier, this interval was given as 10 years, but remember, this is a common lesion. We encounter this very often in day-to-day practice, and it uses up a lot of resources if you need to follow up these lesions. In fact, a lot of institutions have their own modifications of these surveillance guidelines, because it's clearly very difficult unless you have all the resources in the world to do such frequent surveillance. These are again based on the high-risk stigmata and the worrisome features, the indications for surgery. More important than that, than just the size of the lesion, is the morphology. If you see solid areas, as are seen in the head lesion here within this cystic lesion, so there is a cystic lesion, but there are some solid areas within that, that's when you want to start worrying about it. You want to subject this lesion to an EUS-guided FNA. If required, you want to do a genetic analysis, because remember, these patients are positive for GNAS mutation, and GNAS has been associated with a high-grade dysplasia in these IPMNs. This is an MR of the same patient showing you solid areas within that lesion in the head, and this patient was finally subjected to surgery and was found to have an invasive adenocarcinoma arising in a background of IPMN. To complicate matters further, sometimes chronic pancreatitis may coexist with mucinous, with IPMNs. This was one such patient. Very unusual. The pancreas is almost completely replaced by fat. This is calcification in the main pancreatic duct, and there is this large solid cystic lesion, predominantly cystic, but there are solid areas within this lesion as well. This was a patient with combined IPMN as well as chronic pancreatitis, and there was a malignancy associated with the IPMN, the main duct IPMN, when this patient was subjected to surgery. It's difficult to evaluate smaller lesions because they do not show the typical features, but it's sometimes even more difficult to evaluate very large lesions because they lose some of the typical features that you have read in the textbook. This is perhaps the largest IPMN that I have seen in my practice. There is a large cystic lesion involving almost the entire pancreas, but notice it becomes easy to discern the ductal appearance of this. This is a tubular appearance. This is actually a grossly dilated main pancreatic duct with a large lesion involving the tail, which has solid areas. So this had even ruptured into the stomach. If you see here, this large malignancy associated with IPMN has already fistulized with the stomach, and this patient was subjected to a very extensive surgery where a total pancreatectomy, gastrectomy, splenectomy was done. And this is the operative specimen, and the histology showed that this was an invasive ductal adenocarcinoma arising in the background of IPMN. Another concept that I want to introduce is what is called field defect. This is a 64-year-old male patient who presented with jaundice, and you can see this focal dilatation of the main pancreatic duct here. Then it reverts back to somewhat normal caliber. Remember, when you are seeing IPMN in any part of the pancreas, you must look at the entire pancreas to detect any concomitant ductal adenocarcinoma. This is considered like a situation like cirrhosis, that when you have one HCC, you need to look at the entire liver because the background liver may also show HCC. When you have IPMN in the pancreas, the background histology of the pancreas is abnormal, and there can be a concomitant pancreatic adenocarcinoma even in that part of the pancreas which is not involved in the IPMN. So this was a main duct IPMN. Some more magnified images of the same. There was a double duct sign here. The pancreatic duct was getting cut off, and the CBD is also dilated above that level by this hypo-intense lesion, which is causing a cutoff of the duct. And on the T2 weighted image, we could identify a solid looking lesion in the head of pancreas in this patient who had main duct IPMN. So remember, you have to scan the entire pancreas when you see any involvement with IPMN, because there is what is called a field defect, and this patient had an invasive ductal adenocarcinoma in the region of the head. The IPMN was in the region of the body and tail. So this is the concept of field defect in background of IPMN. Let's move on to the next lesion, solid papillary epithelial tumor. This is a tumor that occurs in young women. One of the hallmarks of this lesion is the presence of hemorrhage in this. Again, MR is superior diagnosing hemorrhage. This is a T1 pre-contrast image which shows you these T1 bright areas. There is a T2 dark capsule around these lesions because of the hemosiderin rim that is there, and then there are cystic and solid areas. This, in the appropriate clinical context and in a young woman, would suggest a solid papillary epithelial tumor. These can be very large at the time of presentation. Notice the cystic predominance of the lesion, but there are solid areas as well. Another example on MR, on T1, hemorrhage within the lesion, large solid components within a predominantly cystic lesion in a patient with SPEN or solid papillary epithelial neoplasm. This is just a summary of what we have gone through. This is given in the literature, so I won't spend too much time. Spend a minute about the needle aspiration of these lesions. The gastroenterologists, when they aspirate a mucinous tumor, do what is called a string test. They can just stretch the contents across the index finger and the thumb, and if it stretches for more than a distance of 1 centimeter, it is thought to be mucin. And this string test is a simple way of diagnosing the presence of mucin within a lesion. There are also these mutations in the KRAS and the GNAS gene, and GNAS is fairly specific for IPMN, whereas the KRAS can be seen both in the mucinous cystic neoplasm as well as IPMN. So there is an increasing focus on genetic analysis, both of the cyst fluid as well as of the serum. You can do cell-free DNA, you can do liquid biopsy in these patients, and the assessment for mutations in the KRAS and the GNAS mutations. Coming to the last category of cystic lesions, there is also an entity called the cystic neuroendocrine tumor. You can have small lesions. The feature here which gives it away is the peripheral rim enhancement. When you see a small cystic lesion with peripheral rim enhancement, always keep the differential of a cystic neuroendocrine tumor. These are most often non-functioning tumors, and they are positive on Dotanoc PET CT, so that may be a useful investigation to do in these. I'll just take a minute more. Sometimes when you are scanning elderly patients, you'll identify these very tiny 2 mm kind of lesions. In our practice, at least in an elderly patient, we would tend to ignore these and not put the patient on surveillance because MR time is precious, and in a country with limited resources, you cannot subject all such lesions to surveillance. Having said that, there is a white paper that was published by the American College of Radiology, which gives some guidelines on which are the lesions to undergo surveillance. And you may want to discuss this with your patient before you have a policy or an MDT kind of discussion. These are flowcharts from this ACR white paper on which are the white dots which need to be kept on surveillance. To summarize, in the evaluation of cystic lesions, MR is superior to CT, both for showing the internal architecture of the lesion and for documenting the communication with the pancreatic duct in IPMNs. I've shown you the spectrum of cystic lesions, and the ones that are perhaps most difficult and the most common are the IPMNs. Thank you very much for your attention.
Thank you, sir, for taking us meticulously through these guidelines and helping us make sense of them. Up next, I invite Dr. Sudhir Kale, Lead Consultant and Head Radiology, Aster CMI, on the stage to share his views on pancreatic adenocarcinoma, imaging pointers for operability.
So, Vanakkam Coimbatore. How many of you are enjoying the sessions here? Fantastic, all hands up. I think it was a treat to watch Raju sir's talk. So he has covered with cystic lesions, and so now we'll just move on to the solid part of the pancreatic lesions, that is pancreatic adenocarcinoma. So imaging pointers for operability, current status and update. Okay, so what are we going to do? See, we are just looking into the introduction part, then the NCCN guidelines version 2025, the recent revision, what was the revision made, and what are the usual protocols as a radiologist we need to follow, and then the classification of the tumors once identified. You try to categorize into resectable, borderline or locally advanced. Initially, this locally advanced was in the unresectable criteria, but in the current guidelines, they have all shifted it to locally advanced. Then there are three key imaging findings in an MDT when you want to go. What a surgeon wants to know, maybe if you can add it in your report looks from good to great. Then the TNM staging, and there are I think we are not going to cover pancreatic carcinoma mimics in the shortage, and some reporting template. So coming to the introduction, like complete resection of pancreatic tumor. Complete resection of pancreatic tumor is the only curative treatment option in pancreatic carcinoma. So pancreatic cancer is seldom detected at an early stage. So 40% of the patients when you diagnose are locally advanced. They are unresectable. So and 40% present with distant metastasis. So what are we going to do? I mean, historically we are trying to save those 20%, guide those 20% of the patients. Okay, so coming to the NCCN guidelines, what was the changes that were made? So you can see that introduction part, they made the definition into decisions about diagnosis, resectability and management should involve MDT at a high volume center with use of appropriate imaging techniques. So what are the imaging techniques? So they are MDCT, and that is the rule, and MRI as a problem solving tool. So there were few other guidelines, principles what has been given, that is the high quality dedicated imaging of pancreas, MDCT 64 slice or more is what they are recommended currently. MRI to be used as a problem solving tool for characterizing CT indeterminate lesions, and when suspected pancreatic tumors are not visible on CT or in case of severe allergies. PET CT may be considered after formal pancreatic CT protocol. So PET CT is not a substitute for MDCT, right? And EUS is not recommended as a routine staging tool. In select cases, EUS may be a complementary to CT for staging. Then EUS guided biopsy is preferable to CT guided biopsy because lesser spillage, and biopsy proof of malignancy is not required before surgical resection when the clinical suspicion for pancreatic cancer is high. The decision regarding resectability status should be made by consensus in MDT meetings. So these are few of the things. So helical 64 slice CT or more, then thinnest possible less than 3 mm, and then preferably sub-millimeter 0.5 to 1 mm, and neutral contrast to be used, and pancreatic parenchymal phase, please remember this, 40 to 50 seconds, and the portal venous phase at 65 to 70 seconds is recommended. And as far as MRI, regular T1, T2s, diffusion is key. Try to have a good diffusion weighted imaging, plus always add, irrespective of whether they ask for MRCP or not, add MRCP to your protocols. Then this is a little bit of overall thing, like whenever there is a clinical suspicion, you either plan a CT or MRI. Then based on the multidisciplinary, if it's a non-metastatic disease, again you can do a whole body CT or a PET CT if required. And if there is a metastatic disease, that particular metastatic disease requires confirmation. Okay, so what imaging information is required? So this is what it is, like size of the tumor, lymph nodes and metastasis. Is this enough? No, we need to know many more things. That is the key points of resectability. So that is the involvement of critical vascular structure as far as NCCN criteria is concerned, and then invasion of nearby structures like transverse mesocolon, mesentery and perineural invasion. Okay, so now let's look into NCCN guidelines, which becomes the basis for our reporting system. So we divide this into 3 categories, like resectable, borderline resectable and locally advanced. So you have artery on one side and venous on other side whenever we do report a pancreatic neoplasm. So if there is no contact of the tumor with the artery nor with the vein, then you can straight away tell these are all resectable cases, provided there are no mets. Then coming to the borderline resectable have been called whenever the contact is less than 180 degrees. I'll show you in the next slides. Or the portal venous system, even it can be less than 180 or little more than 180, but it should be reconstructable. And locally advanced are whenever the surface solid tumor contact is more than 180 degrees, or whenever you have so much of involvement of vein which is not, reconstruction is not possible. So now the terminologies in your reporting, whenever it is the contact is less than 180 degrees, use the terminology abutment, and whenever it is more than 180 degrees, use the terminology as encasement. Then coming to resectable, so as we told, there is no arterial contacts. So either mainly 2 arteries, remember, like celiac axis and the right hepatic artery and the SMA. And then the venous contact, what do we mean by venous contact? That is superior mesenteric vein and the portal vein. So less than 180 degrees without any vein contour abnormality are considered as resectable adenocarcinomas. So now what are we seeing here? We are seeing a lesion here. And what is this structure here? SMV. What is this structure here? SMA. So is the fat plane between the lesion and the vessels maintained? So do you call it as now resectable or borderline resectable? Resectable. Good. Perfect. So okay, so this is how we are going to look into it. Now let's move on to the borderline resectable. So where the celiac axis or SMA, where the contact is less than 180 degrees, right? And the venous contact more than 180 degrees, and the portal vein, you can see here, like whenever the venous contact is more than 180 degrees or less than 180 degrees with contour abnormality is also fine. Okay. Or sometimes there may be a tumor contact with IVC. That is also okay. Still we can consider this as borderline. So why do we look into it? Because these borderline resectable adenocarcinomas, you are going to give neoadjuvant chemo followed by reassessment and surgery. Right? Now coming to this, so here the celiac axis is free, and here is the tumor, SMA, the contact is less than 180 degrees of an arc of a circle. So then the portal vein, again the contact is less than 180 degrees. So what do you, how do you want to categorize this? This is resectable or borderline resectable? It is borderline resectable, correct. So you can see this another case, again here the celiac axis, you can see less than 180 degrees contact. You can see the upper part when you draw a horizontal line, so the contact is definitely around 150-160 degrees. And you can also see this is an SMA where again the contact is less than 180 degrees, right? So again this is another case of borderline resectable. So when do we tell it as locally advanced adenocarcinomas? As I told earlier, these were called as unresectable, but now the category has changed. They have been maintained as locally advanced adenocarcinomas as per the NCCN. So the celiac artery more than 180 degrees whenever the contact, so that is when we start telling it as encasement, not abutment, and SMA more than 180 degrees again, and also the first jejunal branch of SMA, okay, the arterial contact, that is also very critical to note during your reporting. And also the venous contact, SMV or portal vein, when there is significant tumor encasement, making them unreconstructable. But nowadays the reconstruction techniques have much improved. They are able to reconstruct everything, but still this is terminology, still they are keeping it, that whenever it is unreconstructable, that is when they are going to tell it as locally advanced. And contact with the most proximal draining jejunal vein, and distant metastasis like liver mets, peritoneal mets, omental mets are considered to be locally advanced. So you can see, unlike our previous case, here the contact is going from here entirely crossing more than 180 degrees. And and then the superior mesenteric vein, I mean, you can see this is the confluence. Superior mesenteric vein is completely encased, almost occluded. So this is unresectable. So another 54-year-old with locally advanced, you can see that there is a complete, the lesion is completely involving the celiac axis, celiac artery here, and here the SMA is free, but since the celiac axis is involved, it makes unresectable. Another companion case showing the celiac axis entirely involved more than 180 degrees, and SMV is also involved. Also, please take a note that sometimes there could be retroperitoneal metastatic nodes which are encasing the these vessels. So those are also kind of unresectable, locally advanced cancers, right? So again, you can find these are few other case. Same case had the portal vein more than 180 degrees and portal vein contour abnormality. And another case of locally advanced adenocarcinomas, SMA completely encased again by the primary, celiac axis is encased by the metastatic nodes here. You can just nicely see. And again, SMV complete non-visualization because of the mass, and see, the SMV is not visualized, right? And then so this is a patient with pancreatic adenocarcinoma with a liver metastasis. So all these findings you need to and also please look into the peritoneum. It doesn't end with this. So peritoneal mets is also a known entity in pancreatic adenocarcinomas. So please look very carefully to the omentum, mesentery. Okay, you can see this nice omental nodules here, right? And coming to a little bit point on venous reconstruction techniques, you can see that there are various reconstruction techniques, like there could be a removal of the tumor along with a cut part of a vein, and this internal jugular venous graft is being placed here, or sometimes just a removal of this plus the primary anastomosis, because if the veins can be pulled, they are then they can be stretched and they can be directly stitched. And sometimes only a patch may be enough, like a small patch is cut, the lesion is cut and a small patch, venous patch is put. And similar lines, arterial reconstructions, there have been a significant progress, and you can see that the tumor is removed, and the end to end, again the primary anastomosis is possible, as well as at some instances with lot of micro surgeries currently, even there is a graft placed between the cut ends, like so graft reconstruction techniques. So now I think I just come to an important announcement here, all of you here. How many of you are SOI members here? So I urge everyone, go to the SOI website or reach out to us. So be SOI members. And also I would like to welcome to Soiicon 2026, 8th annual conference of Society of Oncologic India. So this is at Bangalore next year. And mark your calendar, it will be the month of September, most likely third week of September. Okay, will you all be there? Okay, good. So I think I am really thankful for KMCH for raising the bar. They have really done a wonderful job. I mean, and really it's been a scientific treat here. And so now coming to this, after the basic understanding about the lesion, characterization of this, looking into vascular. So what else a surgeon wants to know? So it's very, very important that the surgical planning and MDT, you can add value to the reports. So firstly, I would like to highlight the presence of the few of the structures. You can see that the superior mesenteric vein, this is the main middle colic vein and the gastrocolic vein. And you can see that the gastrocolic, this small horizontal structure, okay, this is the SMV. Start seeing it in your scans now. Like, so this particular structure, if the tumor is involving this, again, this patient might end up going for transverse colon resection. Right? So also this, you can always give a heads up to them that this particular vein is encased, infiltrated. So so they will also be well prepared for, because it's an extension of the surgery. Then coming to the root of small bowel mesentery, as you know, the abdominal reads, I mean, you start with omentum, bowel wall layer, mesenteric layer, and root of mesenteric layers. So this is how most of the abdominal imaging malignancies are being read, and the presence of involvement of the mesenteric root is very critical. So if there are structures which involve the mesenteric root, has to be it has to be written in the report. And then coming to the indirect signs, these most of the patients present with backaches, you know, there will be celiac axis, there will be injections. So you know that what are the indirect way to know that there is a perineural infiltration. So this is from the celiac axis. You can see the green structures here. So these are the plexus and the ganglion around the celiac and SMA. So whenever in CT you see the celiac axis, indirectly you can infer that even there will be involvement of these neural plexus. Then coming to TNM staging, yeah, there is a lot of things as per the NCCN guidelines. To make it very simple, I just put like T1 stage less than 2 centimeters, 2 to 4 is stage T2, and T3 is more than 4 centimeter, and T4 are the ones where the celiac, SMA and hepatic arteries are involved. And this is the diagrammatic representation of that. And coming to end stage, yes, there is little bit importance here. So you should know the difference between the standard node, standard lymphatic, regional nodes and the metastatic nodes. So peripancreatic nodes, periportal, common hepatic, all these nodes just require the standard lymphadenectomy. And all the nodes to the right of SMA, still it's an optional extended lymphadenectomy. But always I want everyone to keep note of this. If the nodes are to the left of SMA or para-aortic, left of SMA, they are considered to be distant metastasis. So just like this in this schematic diagram, you can just see that the nodes which are on the left of SMA here, or the para-aortic nodes, are considered to be distant metastasis. Okay, rest all the green ones are fine for the surgeon, they just undergo a standard lymphadenectomy. So coming to M stage, as we already discussed, 40% of the patients with pancreatic cancer have distant metastasis at the time of presentation. So hepatic around 20 to 75%. So where to look for in metastasis? Look for your livers, look for the peritoneum, look for pulmonary. So at least if you cover these three organs whenever you see a pancreatic cancers, you are at least covering 90 to 95% of the distant metastatic regions. Okay, subcapsular location, suspected peritoneal spread. Okay, then coming to the template for reporting, lot of reporting templates are there. You can take this from the NCCN guidelines directly from there. And so generally you try to look at the morphologic evaluation of a tumor size, length and all like that. And then you try to look for the arterial contact and any arterial variations. And next will be the venous contact and any venous variations. And so this is how your reporting format should look like. I mean, location, periampullary, head, body and tail, morphology, solid, cystic, mixed, diameter, largest diameter in millimeters. Yeah, but you need to take all three plane measurements, because most of the patients requiring neoadjuvant chemo they will be coming up for follow-up. So to assess the treatment response, it's important. And look into the enhancement pattern, CBD and pancreatic duct. Diameters are important, and if there is any stent put it, and the parenchyma, how is the most of the times patients with pancreatic adenocarcinomas in the head and neck, how will be the body and tail of the pancreas in the patients with the malignancy of the head? It will be normal or atrophic. It will be atrophic. Whenever you find an atrophic body, disproportionately atrophic, please suspect. Even you can pick up isodense lesions on CTs. Okay, so then you can ask for MR. Whenever, please just look into this. So sometimes the indirect signs will be like just a simple ductal dilatation. And reporting format for vasculature, yeah, celiac axis, portal vein, and SMV. Look for the length of the venous involvement, contact, and stenosis. And then also look for its invasion of adjacent structures and T and M and M stages, right? And so the take-home guidelines, so NCCN guidelines version 2025 tells MDCT is the mainstay, 64 slice and more. MRI can be used as a problem-solving tool. No PET-CT at the first instance, cannot replace MDCT. And then coming to the categorizations into 3 categories: borderline unresectable, borderline resectable, and locally advanced, and 3 key imaging findings what surgeons wants to know, like the gastric colic vein, perineural involvement, and then the TNM staging, pancreatic carcinoma mimics I have not covered, so a reporting template. With this, I would like to end my talk. Thank you.
That was yet another excellent talk that showed us how we can help better guide the surgeon in a case of pancreatic malignancy. Next, I welcome Dr. Anu Iyappan, Professor, CMC Vellore, on stage to shed some light on pediatric abdominal malignancies.
Good afternoon. So I'll be speaking on pediatric abdominal malignancies, a case-based review. So because of limited time, we'll dive into the topic straight away. So this was a 5-year-old girl who presented with progressive abdominal distension for 2 months. So she had a CT which showed a large retroperitoneal mass, suprarenal mass extending down, merging with confluent adenopathy, encasing vessels. You can see the aorta lifted up, a lot of calcifications. So this was neuroblastoma. She also had a PET CT where there was metabolic activity in all the nodes as well as bone marrow. So this was metastasis to nodes as well as the bone marrow. Post chemo, she had chemo, and after about 4 months had another repeat imaging, and you can see that there's significant reduction in the bulk of the retroperitoneal mass and also with a lot of calcification. Now this was a 3-year-old girl with a palpable right upper quadrant mass and pain, and again you can see a large right suprarenal mass crossing midline. On the second CT image you can see that there's infiltration of the liver, and on the coronal scan you can see kidneys displaced inferiorly and infiltrated. So this was again neuroblastoma. So a word about neuroblastomas. It's the most common extracranial solid malignancy of childhood. The median age at diagnosis is about 19 months. It's a tumor involving the peripheral sympathetic nervous system. So the way it can present, it can be a localized tumor. You can have widespread dissemination. You can have MS disease, which we'll come to. So the stage at which at the time of diagnosis is probably the most important prognostic factor. So the modalities for staging, you have to do both anatomic staging as well as imaging and functional imaging. So for anatomic imaging, it is either CT or MR. Functional imaging is done with iodine-123 MIBG labeled with SPECT. And FDG PET, as per guidelines, is indicated only for MIBG negative tumors. Of course, there are other modalities like whole body MR, diffusion, etc. for anatomic imaging, as well as somatostatin analogs which are being explored, but these have not come into the guidelines. Now, staging system, the initial early staging was the INSS, International Neuroblastoma Staging System, which was actually a post-operative staging system. Now, in 2009, that was the new staging system, International Neuroblastoma Risk Group Staging System. This is a pre-operative staging system, and so it is partly image-based, and this is where radiology has a role. So stage L1 is localized tumor not involving any vital structures, or IDRF negative. What IDRF is, again we'll come to. Stage L2 is loco-regional with involvement of one or more IDRF. So IDRF is actually image-defined risk factors, that is vital structures in each of the body regions, the chest, the abdomen, the neck, etc., which are involved by the tumor. And so presence of one or more of these risk factors in each of these regions will make it loco-regional and no longer local. Stage M is metastatic disease, and stage MS, this is metastatic disease in children less than 18 months with mets to skin, bone marrow or liver. So this is some IDRFs for the abdomen. So involvement of multiple compartments rather than one region alone is again an IDRF. It makes it loco-regional. In the abdomen, tumor involvement of various structures are listed out. So this involvement can be encasement, infiltration or invasion, and there are specific definitions for each of these. And for example, encasement would be more than 1/2 of the circumference. Infiltration is involvement of non-vascular structures or other organs with loss of interface and loss of definition of margin. Invasion of the renal pedicle is what is specifically described as invasion. So these are some examples, loco-regional. The first image, you can see a bulky retroperitoneal mass, suprarenal extension into neural foramen. So neuroblastomas tend to go into neural foramen, and so this is again loco-regional, L2. And the second image on top, you can see again bulky mass encasing the aorta, lifting up the aorta. So this is again loco-regional, and the lower image is metastatic because there are bulky supraclavicular nodes. So moving on, there's an infant girl with abdominal distension and being evaluated for a mass. So she had an MRI which shows large heterogeneous mass on T2. These are coronal and axial T2 images with a lot of cystic areas, etc. And the post-contrast image again shows heterogeneous enhancement. And so this was hepatoblastoma. This child also had markedly elevated serum alpha-fetoprotein. So another child, 1-year-old boy with suspected liver mass, and you can see this child had a CT, and you can see a heterogeneously enhancing mass involving all the segments of the liver, and again there was markedly elevated serum alpha-fetoprotein. So coming to the differential diagnosis of liver tumors in early childhood, that is in the 6 months to 6 years, tumor markers are definitely important here. Elevated alpha-fetoprotein is seen in hepatoblastoma. This is the age, whereas the other tumors which can occur at this age, hemangioma, mesenchymal hematoma, rhabdomyosarcoma, all these AFP is normal. Age of onset, hepatoblastomas occur in very young children, less than 5 years. Hemangioma is a tumor of infancy. It is a benign tumor. And mesenchymal hematomas also occur in the very young age, mostly less than 2 years. Biliary rhabdomyosarcomas again less than 5 years, and it's a rare tumor. So hepatoblastomas, as we have seen on this, they are heterogeneous, whereas the hemangioma, infantile hepatic hemangioma, they have that typical enhancement, intense peripheral nodular enhancement and the centripetal fill-in. And mesenchymal hematomas are predominantly cystic. Sometimes they can be solid and can mimic a hepatoblastoma. Of course, then you have to look at the alpha-fetoprotein and all that. Whereas biliary rhabdomyosarcomas, they typically occur near porta hepatis, and they have an intraductal growth pattern. So hepatoblastomas again can have coarse chunky calcification. So whenever we see a liver tumor in a very young child, some of the other things to keep in mind, the tumor markers, and look at all the additional features, calcification, the enhancement pattern, and that may help you to narrow down the differential. So a word about hepatoblastoma. They are the most common primary malignant tumor in children less than 5 years. Majority of them are sporadic tumors. Few syndromic associations like Beckwith-Wiedemann, familial polyposis, trisomy 18, just to name a few. As we said, there are elevated alpha-fetoprotein. And staging of hepatoblastoma is important. So what we use is the pre-treatment extent of disease, or the pre-text staging system. And so in this, the liver is divided into 4 sections based on the segmental anatomy. You have the left lateral, left medial, right anterior and right posterior segment. Caudate lobe is looked at separately, and so you have the pretext groups and annotation factors. The pretext groups are basically tumor 1, 2, 3 or 4. The groups depend, so it depends on the extent that the tumor has involved the liver. And so how you calculate the pretext group is look at the number of contiguous liver segments, sections which you have to remove, so that you have a completely tumor-free liver. So this is something I've taken from radiographics. So pretext 1 is 3 contiguous hepatic sections must be tumor-free. So if either the right posterior or the left lateral is involved, just that can be removed. As seen on this image, you can see the borderline, the right hepatic vein, which tells you that the tumor seen on that image is entirely within the right posterior sector. So again, that is pretext 1. Pretext 2 is tumors, it can be either in the left lobe or in the right lobe, involving either 1 or 2 sections, so that you need to remove only 2, so that you leave behind 2 contiguous tumor-free sections. So on the CT image, that arrow points to the middle hepatic vein. So only the right lobe sections are involved, the right posterior, right anterior. So pretext 3 is tumor involved either 2 or 3 sections with only 1 contiguous section which is tumor-free. And pretext 4 is involvement of all the 4 liver sections. So moving on, this is the pretext. The annotation factors are also important. So you have to look at each of these separately and say whether they're present or not. V is for the involvement of hepatic veins, IVC. P, portal vein, is extrahepatic spread, multifocality, so the list is there. Caudate lobe and lymph node involvement is also included in this annotation factor. They do not come into the main pretext group. So moving on, 2-year-old boy with abdominal distension and a vague mass since 3 months. And what we see here is a large mass in the left kidney, little sparing of the upper pole, and it looks like there is extension of tumor into the collecting system, no renal vein invasion. So this was Wilms tumor. And so the main differential diagnosis sometimes is the neuroblastoma, Wilms versus neuroblastoma. So the claw sign, where the kidney forms a claw-like edge at its interface with the liver, tells you that this is likely to be of renal origin or a Wilms tumor, as seen in the second image below. And whereas the neuroblastoma will not do that. Then the presence of calcification is a feature of neuroblastoma, extensive calcification. Wilms actually is a tumor with very little calcification. Wilms, as you know, can invade the renal vein, it can extend into the vein, whereas neuroblastoma, they encase the vessels, they can lift up the aorta, but usually they do not. Invasion is a feature of Wilms. And the other features that you see with neuroblastoma, crossing midline, extending into spinal canal, all these point towards a neuroblastoma. Now the differential diagnosis for a renal mass in early childhood. So Wilms tumor is the commonest, as I said. So peak age is 2 to 3 years. Renal vein invasion is an important feature of Wilms tumor. Now the other tumor which can invade renal vein is the renal cell carcinoma, but this in children occurs in the second decade of life. So that so in a very young child you wouldn't consider renal cell carcinoma. Congenital mesoblastic nephroma occurs in neonates. It's a solid tumor. Sometimes you can see that ring sign with alternating hyperechoic, hypoechoic bands. Then clear cell sarcoma, again, it's less than 6 months. It's usually a tumor of childhood, early childhood, but one important feature is bone metastasis, whereas rhabdoid tumors, again, peak age is around 11 months. They have a high association with CNS tumors. So briefly about Wilms tumor, 90% of pediatric tumors, precursor is the metanephrons, and they're heterogeneous tumors with areas of necrosis, hemorrhage. Most of them are sporadic. About 10 of them can have a genetic predisposition, and in these, more than 60%, the tumor arises from nephrogenic rests. So what are nephrogenic rests? These are persistence of the renal embryonic tissue beyond 36 weeks gestation, and the metanephric blastema, and this can give these are called they can give rise to Wilms. So there are two types, perilobar, like we see on this first image. They are peripherally located. They can be seen as a rind of tissue around, and when its involvement is diffuse like this or multiple, it's called nephroblastomatosis. And intralobar, this child also had intralobar. You can see discrete nodules most centrally located. So this child also had a Wilms tumor. This was a 7-year-old girl. And the second image is of a 3-year-old girl with bilateral renal masses. This was a recent patient where you see multiple masses in the kidneys. Many of them are uniform, homogeneous, well defined. So this again was nephroblastomatosis. Now the thing is, you can see there are tumors on the lesions in the right and left kidney which are starting to enlarge, look very heterogeneous. So this is the onset of bilateral Wilms in this child. And these again have association with many syndromes. 4-year-old boy with large mass in the abdomen, and this you can see a large mass from the right kidney, lot of extrarenal component, heterogeneous enhancement. This was actually a clear cell sarcoma on biopsy. This can mimic Wilms tumor, but things like renal, it's much more common as the Wilms tumor. Renal invasion is a feature of Wilms tumor. One thing which can tell you is the unusual presentation for a Wilms, like bone mets, which doesn't occur with Wilms, is seen more commonly with clear cell sarcoma. Then this was a 5-month-old girl with an incidentally detected left renal mass, also had a 4th ventricular mass. So what you see here is a heterogeneous mass from the left kidney, and you can see the arrow points to a subcapsular fluid collection, and on MR there was a 4th ventricular mass with cystic and solid components. So this was a rhabdoid tumor of kidney. These are rare tumors, usually occurring less than 2 years. They're usually associated with a synchronous brain neoplasm, usually in the posterior fossa. It can be rhabdoid tumor, medulloblastoma, ependymoma, etc. And one classic feature on abdomen imaging is that subcapsular fluid collection, which tells you that this could be a rhabdoid tumor. Calcifications are much more common than Wilms tumor in a rhabdoid tumor, but these are again very rare tumors. And this is another tumor which can invade the renal vein. So this was a two-month-old infant with 2 episodes of hematuria. So you can see ultrasound shows a polypoid kind of mass in the urinary bladder. CT again an intensely enhancing polypoid mass in the urinary bladder. This was embryonal rhabdomyosarcoma, and so you can see that little, almost like a grape-like appearance. And this was another child, a 3-year-old with bladder outlet obstruction. You can see that again, bunch of grape-like polypoid lesion at the bladder base. This is also known as sarcoma boteroides. It's a form of embryonal rhabdomyosarcoma. And this was another 4-year-old girl who presented with a perianal mass. You can see a bulky mass in the perianal region on a T2 MR, sagittal and axial. And this turned out to be an alveolar rhabdomyosarcoma. So a word about rhabdomyosarcomas. These are the most common pediatric soft tissue sarcomas, occurs usually around 5 years. The common sites are head and neck, GU and extremities. 40% in the pelvis. More common is the embryonal type, which is about 75%. Alveolar is about 20% and pleomorphic is about 5%. Another 3-year-old boy with a palpable abdominal mass. So this, you can see a bulky mass on the right side involving the colon and the terminal ileum. So this turned out to be NHL. Non-Hodgkin's lymphomas are much more common in the pediatric population. They are more aggressive, they have more extranodal involvement, and they more commonly affect the GIT. So this patient, this turned out to be a Burkitt lymphoma. Burkitt lymphoma is actually a very highly aggressive form of B-cell lymphoma with a very short tumor doubling time. So another child, 13-year-old boy with a palpable mass. You can see bulky adenopathy, bulky confluent adenopathy. This was PET avid, and this turned out to be a large B-cell lymphoma. Lastly, germ cell tumors. This was a 14-year-old girl who was incidentally detected to have an ovarian mass. And so germs, this turned out to be this germinoma. So origin of these is arise from primitive germ cells, usually the gonads, the testes or the ovaries, but some of them can be extragonadal, usually in the midline, for example, a sacrococcygeal teratoma. So they're broadly divided into seminomas and non-seminomas, and the female version of it will be the dysgerminoma, seminoma, dysgerminoma, and the non-seminomas are the embryonal cell carcinoma, choriocarcinoma, yolk sac tumor, and teratoma. Now, germ cell tumors again have a bimodal peak. On imaging, seminomas are homogeneous, non-seminomas are heterogeneous. And tumor markers, alpha-fetoprotein will be elevated in yolk sac tumor and embryonal cell carcinoma, beta-HCG in choriocarcinoma, and LDH in seminomas and dysgerminomas. So to conclude, pediatric abdominal tumors, it's a wide spectrum. Important to look at the age of presentation, tumor markers, that will help you to narrow down your differential. MR is useful in staging and follow-up because it is radiation-free, good soft tissue resolution, and imaging therefore definitely has a role to play. Thank you.
Thank you, ma'am, for taking us through those interesting pediatric abdominal cases, which was very useful. We now proceed with the discussion session.
Thank you. Thank you all the speakers for such a wonderful session. There are few questions from our participants. The first question is, why is fatty liver a criteria for inoperability in hepatic cholangiocarcinoma? I think Dr. Madhu, he's not here, but fatty liver is not a criteria for inoperability. Only thing is, if you're operating on a fatty liver or NASH or in presence of cirrhosis, if your FLR, the future liver remnant, has to be more. Fatty liver per se is not a criteria for inoperability. Dr. Anu ma'am has a question for you. Your case of 3-year-old perianal mass, alveolar rhabdomyosarcoma, looks like swirling imaging pattern of aggressive angiomyxoma, except for age. Any other clinchers for diagnosis?
To make a this was actually non-contrast imaging. So what we were seeing is a bulky mass in the perineum. I don't know whether you can make a thing of an angiomyxoma without seeing the contrast enhancement. So we had thought this could be a rhabdo because probably between the two, this may be a little more common. I'm not sure.
Okay. So next question is to Dr. Anu as well. Both nephroblastomatosis and bilateral Wilms, how will we differentiate? Both are bilateral. And how many times bilateral nephroblastomatosis progress to Wilms tumor?
So, nephroblastomatosis is a term we use when we have multiple nephrogenic rests, or when it's like diffusely involving the kidney. But each of these, if they are non-malignant, will generally be homogeneous in appearance and generally smaller sized. So once you see a larger mass with heterogeneous or mixed signal intensity or mixed attenuation on CT, then you have to think, is it developing a Wilms tumor?
Thank you, madam. So there are a few questions from the pancreatic adenocarcinoma of the head. So Dr. Sudhir is there. Okay, there are a few surgical things which I can answer there. So, sir, how can to locate the first jejunal branch of SMA is very small in caliber, and also why does its involvement make tumor unresectable despite its being such a small branch? So, technically, everything is resectable in a pancreatic head, even if it's involving the artery or vein. Technically, it's resectable. But the thing is, whether it converts or translates into survival benefit is the main question. So, involving the first jejunal branch, especially the artery, it's a sign that the tumor has already invaded the root of the mesentery. And the clearance like R1, R0 clearance, we can't achieve in that situation. So that's why it's deemed as inoperable. So it's like, as I said, it's all technically resectable, but the important thing is to give the survival advantage. So that's the main thing. Yeah. So in pancreatic adeno-CA resectably, how to determine vein is unreconstructable? Any cutoff is there? So as we go down more distally, like SMA, and then it's going just below the SMA, it's branch out into small multiple branches. Technically, as I said, we can do it, but the thing is, the vein usually, if it's reconstructed, it's more prone to thrombus. So if it's very small in caliber, so definitely if you reconstruct, it will thrombus within a few days. So it not be of no use, and sometimes it will also be difficult because the vein is very thin, and if we take bites, it will keep on tearing. So what in our unit, what we practice is if it's involving SMA and its branches, so we don't resect, and at the same time, if it's involving the confluence like splenic vein and the portal vein, yes, we can do it technically. We can put a branch patch and retreat from the great saphenous vein. So, but again, what survival advantage it gives is the main thing.
Raju sir, two questions for you. Somebody wants to know more about what is field defect. You showed a case with.
Yeah.
And second question is, can SPEN happen in head as well?
Can SPEN occur in the head?
Head region of the pancreas as well. These are two questions.
So I'll answer that first. SPEN can occur in any part of the pancreas. Yeah. Field defect is a concept that you can develop, the patient can develop adenocarcinoma remote from the site where the IPMN is. Patients who have IPMN have an increased predilection to developing adenocarcinoma in two ways. One, the IPMN itself converts into an adenocarcinoma. Second, remote from where the IPMN occurred, the rest of the pancreas is also more prone to developing adenocarcinoma. That is what is called a field defect.
Thank you.
Ganesh. Not here. Any more questions from the audience before we conclude this?
Nephroblastoma or any Wilms tumors, many institutes are doing CT only, but considering pediatric repeated radiation, can we move on to MRI already? Like
MR is a modality. The constraints are usually the finances and those kind of things. But otherwise, MR would be the better option in a child.
like just a coronal T2 would be enough, like T2 and DWI, like, or would you recommend contrast as well?
Yeah, T2 and diffusion again will help, but contrast imaging is also useful for tumors.
Okay.
To look at other things like renal vein involvement and those kind of things.
Actually, I'm working at Johns and I am regularly part of pediatric tumor boards. It is becoming very difficult to convince to shift to MRI because they are very used to CT and they can interpret the CT partly. For MRI, then the child might need sedation and anesthesia. Those are few difficulties. But if cooperative, like I thought, like MRI should
even
be
limited MR is also an option for follow-up, like especially if there are financial constraints.
Okay. Any advice on like how to convince the fellow clinicians to move on to MRI?
As many MDTs as you can possibly have and show them few examples where CT has missed and MR has picked up the finding. You know, the proof of the pudding is in the eating. You have to show some examples to them where MR scores over.
Radiation
Then they'll definitely
also,
agree.
sir,
There's no issue.
Radiation doses,
Yeah, absolutely. That you have to keep on
multiple
talking.
phase is acquired and
Totally agree with you that for pediatric imaging, we should increasingly switch to MR, whether it's liver tumor, whether it's follow-up of nephroblastoma. In all these situations, MR is the way to go. And repeated conversation with the clinicians is the only way forward.
thank you, sir.
Thank you. From this, we conclude the session. Thank you for the participant and the speaker who gave us wonderful presentation and enlightened us with many new things. Thank you.
We thank the chairpersons for addressing all the